Hi, this is Dr. Diane Gehart, and this is my lecture on treatment planning based on my book, Mastering Competencies in Family Therapy. And you can follow along with this lecture reading Chapter 4 from the book. In addition to progress notes, treatment plans are probably the most common clinical document used in practice today. And so you'll be doing a lot of these in the years ahead. And treatment plans are, just like what they sound, are a plan for treatment. And so how you basically plan to go about addressing the problems that the client has brought to therapy. And the treatment plan typically outlines the type of theory and techniques that you plan to use. And when choosing these, you need to think about what best fits the client, the specific problem they're bringing to therapy, what's a good fit for the therapist-client relationship, and what does the research and evidence base show typically works for this type of person and this type of problem. So there are a lot of different factors that go into developing a treatment plan. Historically, there have been two different types of treatment plans. The first is a more symptom-based treatment plan that really comes out of the medical model, where the focus and the specific goals in the plan focus on reducing the client's medical symptoms. And the danger with this particular approach that sometimes the focus becomes so much on the problems that you miss the larger picture, the bigger context. And a good common example of this is when parents bring in a child because he's having lots of quote-unquote tantrums. And so if the therapist, focuses on assessing the tantrums and, looking at what's going on with that child and developing a plan around the tantrums, sometimes you miss the larger context, where in many cases a child may be having tantrums, but if you stop and assess the entire family system, you might discover that the issue lies more with conflict within the marriage, and that by addressing that, either alone and or in addition to the child issues, that you would be addressing the tantrums. So sometimes if you're, a treatment plan is based solely on reducing child's temper tantrums to no more than once per month, you would not be likely to be looking at the marriage or adding even goals related to what's going on in the broader family system. So, but the symptom type of plans are the most commonly requested plans by insurance companies because they use a medical model, because they also work with physicians. And so you will often see these kind of more simple plans that are just talking about symptoms and not really addressing larger interpersonal or intrapersonal dynamics. Which brings us to the other type of plan, which is theory-based treatment planning, which uses some clinical theory to develop a treatment plan. The difficulty with these treatment plans is that if they're solely theory-based and they aren't linked to any diagnostic language, that oftentimes it's hard, I've found, for students in particular to make the link between how does reducing enmeshment relate to the tantrum problem, or relate to the depression problem. And so sometimes if you have just a theory-based treatment plans without linking them to the diagnostic symptoms, sometimes it's very hard to make the link back to what's going on medically. So in this book, I introduced something that is called a clinical treatment plan that actually combines both some of the symptom-based language as well as a theory-based language so that you can both talk to insurance companies and relate this back to your particular theory of choice. And so these are long, hairy, gory treatment plans. But what they do is cover all of the bases of what really goes into planning treatment. So in some ways that much more complicated picture is a little more realistic as to what treatment looks like. So let's start breaking this down and making sense of this more complex but yet more comprehensive and more realistic treatment plan. So if you look at this treatment plan, the plan that's in the book, you're going to see that there's an introduction that basically identifies the client and some salient information to just keep in mind when you start putting the plan together, including diversity, issues, language issues, those sorts of things, and key diagnosis and if there's any medication involved. And then you look at the three phases of what's going to be therapy. There's an initial phase where you're kind of setting the stage, developing the relationship, and addressing any of the crisis issues that are burning, and also setting up the goals for future treatment. Then the main phase of what we would think of as therapy is the working phase, and that's where we start getting into addressing the key issues that have been brought to therapy. In the final phase, the termination phase, is where we're solidifying gains, we're addressing any long-term goals that might be part of a particular theory, and preparing the client and her family to be able to maintain their gains without having a therapist to be in the picture. And now within each of these three phases, there are three different components. One is what I would call therapeutic tasks, and these are tasks that are common across all therapeutic models and basically constitute standard practice. They're going to be things like creating a therapeutic relationship, goal setting, assessment, termination plans, that sort of thing. So these are common across all approaches and things that should be done every time. Then the second component are client goals, and these describe goals that are unique to the client. And so these are the goals that you would typically see on a symptom-based treatment plan and or a theory-based treatment plan, very specific to the client. And then finally we have interventions, so for each goal to have 2 or 3 different techniques or interventions that will help, that the therapist plans to use to help the client achieve the goal. And then finally this plan includes a piece on client perspective, which is increasingly recognized even in public mental health agencies, that the client's perspective is very important. Do they agree with this plan or not? Why? And what types of things would help make this plan more believable and agreeable and more hopeful for the client. So let's start with looking at therapeutic tasks, because this is actually the easy part of the treatment plan. So even though they look long and they might look a little scary, this is generally the easiest part of the plan. So in terms of the therapeutic tasks, these are more formulaic and standard practice. Although oftentimes for certain ones of these, each theory is going to have its own language and or interventions for each of these tasks. So if you look at the initial phase, that's where we have the most tasks, and it kind of makes sense. That's when therapists are setting the structure for therapy, doing their assessments, and so doing most of the work. The good news is, if you haven't done therapy yet, I know those first few weeks at a practicum placement site, you're like, oh my God, there's so much paperwork, I'm going to die, going to drown. And the truth is, a lot of that is because so much of these therapeutic tasks happen in the early phase. It can be quite overwhelming if you walk in and get 10 new cases, in a week or two. But thankfully, those therapeutic tasks tend to settle down as you go through therapy. So in terms of the initial phase, the first thing is establishing a therapeutic relationship. I think almost anyone listening to this lecture knows that that is so important. It is so key. And until that's there, you really can't do much of anything else. But each therapeutic model is going to describe different ways of doing that. For example, narrative therapy, they talk about getting to know the person apart from the problem. So learning about their hobbies and interests and, what types of passions they have in life is one of the first steps. Where in structural or strategic, they might use a different technique called joining to kind of, talk to the family, ask them, not too threatening questions, and even, how was your drive? How was this? Just to kind of get a feel for the family. So different theories use different approaches for developing a therapeutic relationship. Then the next step is that you'll be addressing intra and interpersonal dynamics. So that's looking at what's going on within the client and also in their interpersonal relationships. Again, each theory is going to have different ways of doing this. Bowenian family therapists like to use genograms to do this. Solution-focused therapists like to assess for exceptions for times when the problem's not a problem. Structural family therapists might use enactments or other techniques to kind of map the family structure. So each theory has a different way of doing it, but usually a pretty standard way of doing it. So again, this is relatively easy to figure out based on what therapeutic model you plan to use. The next initial therapeutic task is developing goals. And so here again, you'll be using the different strategy and techniques within each therapy to do this. For example, the miracle question can be used in solution-focused therapy for setting goals, that sort of thing. And then finally, you have case management and referral tasks. Often when people come in, you're going to find out what's going on in their life, and you may decide that they need a referral for either medical evaluation or a psychiatric evaluation, or they might have some housing issues or legal issues. And generally, you'll notice these early in therapy, and you will need to make those referrals early in treatment. Of course, if issues come up, as things go along, you'll also be making referrals and doing case management tasks as you go along. But generally, the bulk of these are readily apparent when they walk in the door, and so you're dealing with them as they first come in. So the initial phase therapeutic tasks probably sound pretty reasonable and straightforward and make a lot of sense, but it's just good to write all these down and think about how these apply specifically to the particular individual or family that you're working with. Now, when you get to the working phase therapeutic tasks, there's just two basic things. One is making sure that progress is being made, assessing for effective treatment, and maintaining an effective working relationship. And so these two pieces are the main tasks that you're doing in the working phase, and especially when you're working with more than one person, assessing whether or not you're maintaining an alliance with both people in the family and or couple as a whole is very important, as is making sure that treatment is moving forward and that you're actually making a difference. And then in the last phase, the closing phase, you want to develop a termination or aftercare plan. So some kind of plan about how they are going to maintain the gains that they've made and or address potentially new future problems as they arise, knowing that for all of us, life will always come up with a new problem down the road. We can be guaranteed of that. So I'm going to be very honest with you that in terms of the hardest part of treatment planning is writing client goals. Writing good, clear, useful client goals really reveals whether or not you have a handle on the case or not. And so this is going to be the hardest part and the most painful part. And the lucky thing for faculty is that for us, we can, if you've got that right, when we're grading, we can check that. And if those look really strong and solid, generally the rest of everything else falls into place beautifully. So let's take a few minutes to kind of sit back and think about how to write client goals. So the first task is, in terms of writing a client goal, there's a lot of work that goes into that one little sentence, because you do need to complete a thorough case conceptualization and clinical assessment, which we go over in chapters 2 and 3 of the Mastering Competencies of Family Therapy textbook. So already right there you've got several hours of work if you haven't looked at those chapters yet. But what you're doing is putting together the big picture, the case conceptualization, making sure you're addressing any clinical assessment issues, and doing those two things kind of gives you a really nice, juicy description of what's going on with the client. Then you also need to address make sure you're thinking of any major crisis or pressing issues that need to be managed early in treatment. Those are going to go straight into your early phase client goals. But then your big task is to identify 2 to 3 themes from the case conceptualization and clinical assessment that capture and really address kind of the heart of the issue as to what's going on. Because let's say, for example, someone might be depressed. There are many ways to conceptualize this and to frame this so that you kind of have a nice, rich case conceptualization around this. And so if you're just telling yourself, yeah, I want to reduce clients' depressed mood, I mean, that is such a vague goal. I hate to tell you, you really don't need a master's degree or any training to do that. I'm pretty sure that most people with a high school diploma could tell you that if someone's depressed, a basic treatment goal would be to reduce that depression. That much we all know, and you don't need a lot of training for that. But how are you going to do that? I would say that there are thousands of ways to do that effectively. And so that's when you need to step back, look at their case conceptualization in terms of why and how to understand their depression. You can look at it through a narrative lens or a solution-focused lens or a structural lens or a cognitive behavioral lens or a Bowenian lens. There are many ways to look at that, and so you want to look at what's going on and pick 2 or 3 major areas that came up as problem areas in the case conceptualization primarily, and use those to develop your client goals. And so we're going to look at an example in just a minute, but that's the big picture, the big task that you need to do. Finally, you want to look at any long-term goals that your particular theory might advocate for. For example, in Bowen Intergenerational Family Therapy, they talk a lot about differentiation. In Satir and other experiential approaches, they talk about self-actualization. So those are pretty much standard treatment goals, long-term goals that are kind of embedded in the theory itself. And so that's the other thing to kind of keep in mind when you're developing your client goals. So, taking it one step further, looking at the initial phase client goals, generally I recommend that, this is going to be sessions 1 to 3, and you're generally stabilizing any crisis symptoms. So things like suicidal thinking, severe depression, self-harming behaviors, those sorts of things. So an example here might be increasing social engagement and support using the safety plan to reduce social isolation that leads to passive suicidal ideation. So that's a very specific goal. You're increasing their social engagement to reduce the suicidal thinking. And so these should be very specific goals that address what's going on with the client in terms of crisis. And some theories may have some specific goals that tend to be taken care of early in the initial phase, like solution focus might have developing, the identified solution type of thing. So the working phase goal is really the hard part of the treatment plan. And so here you're going to spend a lot of time developing these. But basically you want to address the underlying dynamics that create and or sustain the presenting problem. And so this becomes the frame in using your theoretical language to understand what's going on, and then linking that to the psychiatric symptoms that are in the clinical assessment. And so this is where you're going to be looking at how maybe depressive symptoms from a structural perspective might be caused by either difficulties in the hierarchy or in boundary issues, and meshed or disengaged boundaries. Two totally different treatments need to occur, if the depression is related to enmeshed versus a disengaged, let's say boundaries in the marital subsystem. So you want to look and get very specific as to what's going on. So in one case you might be reducing enmeshment to reduce the depression. In another case you might be reducing the disengagement to reduce the depression. So, and again, you can look at this from a narrative lens, or, every different approach is going to have a very different way to language the specific dynamic that needs to change in order for the psychiatric symptom to be reduced. And then the final closing phase client goals tend to be more global issues, increasing greater health as defined by the particular theoretical perspective, and or just longer term types of issues. So a common one, if you're working from an intergenerational perspective, is increasing differentiation in the marital relationship to reduce the sense of alienation and increase sense of autonomy and intimacy. So in that case, you're really working on more long-term differentiation goals in the Bowen approach. So the final thing you're going to need to write in a treatment plan are the interventions. Now I have to tell you, generally I would say most people get interventions pretty well, and they tend to be an easier part to write, because if you've got good goals, you know what you're doing and your goals are solid, it's pretty easy to come up with the interventions from your theory. So, but you generally want these to be very theory specific, and the more specific you can make them to the client, the better, and the more exact language or exact languaging of the questions you plan to use, the better and clearer your interventions are going to be. So again, here you're going to be citing theory-specific language, so using scaling questions, circular questions, mapping the problem in the landscape of action and consciousness. These are very clearly related techniques related to very specific theoretical orientations. So as you develop your interventions and get better at writing them, I do recommend you actually use the client name or abbreviation, who's going to be doing what for your client, and try to come up with exact quotes or examples of how you might reframe or the type of circular questions you might use in order, especially if this assignment is being graded, to demonstrate that you know how to implement the specific intervention you're recommending. So finally, you want to think about the client's perspective on the plan. in terms of whether or not they agree with the plan, if there are certain parts that might be harder or easier, whether or not the plan really fits for them and their unique needs. Very important to kind of reflect on this, and ideally you will go over the plan, if not in writing, at least verbally with the client, to make sure that they're on board and that they think what you're proposing makes sense to them, because if you don't have client buy-in, it's not going to go very far or be very useful. And I guess we should also add here that the fact is, now that we've kind of walked you through the basic components of the plan, the harsh truth is, and I'll be the first one to tell you this, is that therapy rarely goes according to the treatment plan that you outline. Sometimes it does, but that's not generally the case, that life often happens. But having this plan and having a really clear handle on the core dynamics, the key dynamics that are going on, whether it's you're working with an individual, couple, or family, is going to keep you much more focused on where things need to go. And the more the plan actually focuses on specific key dynamics, the more useful it's going to be, regardless of what other, things happen in the client's life that tend to take their focus away from what's going on. Because if they have a basic pattern, let's say, of being disengaged in their marriage, that, regardless of all the other ups and downs and things that are going on, that core dynamic is likely to continue to be there. And so the better you are at identifying really key core dynamics, the more likely your plan will be able to kind of withstand life happening to your client while they're in therapy. So now I kind of want to just walk you through completing a treatment plan that is included in the textbook. And so you can go ahead and turn to the end of chapter 4 to get a sense of what this looks like. So in the initial part of the plan, you're going to see that there's an introduction section where you put the client identification number, because we try not to use names due to HIPAA. Identify the primary theory you tend to use. You might integrate some other techniques and ideas, but generally your general theoretical approach. The primary configuration, so whether you're working with individual, couple, family. Any medications that might be used, and identifying the contextual factors that are important. Diversity issues, dual diagnosis issues, language issues, key things that you really want to keep in mind when you're developing the plan, and then describing how you plan to adapt to whatever these contextual variables might be, such as gender or language. And so how do you plan to address and make sure that this plan fits for the client based on these contextual factors? And I'll be honest, that part's a little bit hard to write, but it gets you thinking and hopefully thinking creatively about this. And sometimes it's very simple. You're working with an adolescent, and so you might, when I work with adolescents, I tend to use a lot more humor, and I tend to be, frame things in their language in a way that they can understand. If you're working with someone who is, highly educated, maybe doing a certain amount of, psychoeducation. And so kind of addressing whatever, those types of issues might be, and, actually thinking about how you should be adjusting your treatment to fit with the client's unique needs. So here you have a sample of how the initial introduction to the treatment plan can be filled out. This is the sample, which you can probably read better in your book. This is the sample from the solution focus chapter. I believe you can see that. And so you can kind of see how the therapist plans to, introduces the case, and then also talks about how they plan to address some of the diversity issues. So the next part of the treatment plan, as you mentioned before, is the initial phase of treatment and going over those pretty standard therapeutic tasks. And so that's developing a relationship, assessing dynamics, defining and obtaining a client agreement on treatment goals, and then identifying any referrals and case management types of needs that need to be taken care of in the early part of therapy. And again, this can happen at any time, but typically we do that the most in the early phases of therapy. So again, in this example treatment plan, you can see how the therapist plans to learn about each person's strengths, hobbies, and interests, and using humor in order to develop a therapeutic relationship. How in terms of assessment, they plan to use a solution-focused approach of assessing what works, looking for exceptions, looking for the passionate times in the couple's relationship, and also assessing whether or not their level of motivation, whether they're visitors, customers, or complainants. It's a very standard solution-focused stuff. terms of goal setting, this person was thinking of using the time machine question, a very specific variant on the miracle question, using scaling questions to also do goal assessment. And then finally, they mentioned some potential referrals and social needs that the clients might have and need to be addressed in order for therapy to be successful. So again, pretty straightforward stuff that kind of just gets therapy set up and heading in the right direction. So then the next phase here is the initial therapeutic goals. And so here you're looking at goals that generally have to do with any type of crisis issues. And you also want to include criteria for measuring progress. And this is typically what you would see in any public mental health setting. It's real important that those criteria for measuring progress are set. And also identifying one or two interventions for how to work through these initial goals. So here you can see the goal is languaged in beginning either with increase or decrease. And you can use any type of verb that kind of indicates a change in some way. But I recommend trying to work with, increase, decrease, something along those lines with some kind of change verb so that you don't inadvertently begin just writing down a technique as if it were a goal. Some people will talk about, externalizing is the goal. And that's the technique where the goal is always going to be increasing or decreasing some kind of inter- or intrapersonal dynamic. So in this case, they are increasing activities that work for the couple during the dating and good periods in their relationship in order to reduce the arguing or blaming, which is their presenting problem. And so in terms of measuring it, they're talking about being able to sustain this positive affect activities for a period of 4 months with no more than 3 mild episodes of arguing. So you can see that that's, kind of somewhat arbitrary, but that's kind of just the measure they had to know whether or not progress is being made. And of course, this is not an exact science all the time, and that goal and the measurement may be shifted, as they move forward as to what's realistic and what's satisfying and what's not. But it kind of gives you an initial measure, a goal to set forth that all people can be very clear as to when it is reached. And then again, using solution-focused interventions, things like identifying what worked and scaling questions to move them forward with this. Using the formula first session task is another technique they can use to support themselves in this particular first stage goal. So the next part of the treatment plan addresses the working phase of treatment and the therapeutic tasks, which are namely monitoring progress towards the goal and monitoring the therapeutic alliance. Now in Chapter 5, I do go over two measures for these. In terms of measuring progress, there is the outcome rating scale, and then in Chapter 5, there's a session rating scale. Since this is solution-focused, these particular scales are used by solution-focused therapists to measure progress. And so here you can see in the working phase section with therapeutic tasks that they're going to be measuring, progress using the outcome rating scale and measuring the therapeutic alliance using the session rating scale. And again, you can go to Chapter 5 to read more about those. Okay, so here is really the heart of the treatment plan, the hardest part to write, the part that's going to take you the longest to do. So at least there's no false advertising here. So anyway, the working client goals. This is the tough part, and your goal here is to develop 1 to 3 goals that will address the dynamics that create and or sustain the presenting problem. And so there needs to be a change, an increase or decrease in some kind of dynamic. You want to use your theoretical language, especially for the first half of the goal, and then define the criteria for measuring progress. So when you look at the example here, you're going to see that the goals are, in solution-focused language, true to form, are always in the positive. So you're always increasing something in solution-focused therapy. So they're going to be increasing cooperative co-parenting, as they described in their miracle question, since therapists didn't know what that looked like until they asked the question. You're going to be increasing emotional intimacy, and you're going to be increasing couple agreement on each person's role in the marriage and in the family. And so again, you are increasing and addressing and changing very specific relational dynamics. In this case, it's a couple's case. And so all of these then get related to the symptoms. So you're increasing cooperative co-parenting to reduce the triangulation that was talked about in the case conceptualization. For goal 2, you're increasing emotional intimacy and sexual connection to reduce the hopelessness and irritability that was talked about in the clinical assessment. In goal 3, you're increasing the couple agreement on their roles in the marriage and the family to reduce the arguments that were addressed in the case conceptualization. So each one of these dynamical changes that are going on are going to somehow address what's going on in that clinical assessment. So you can begin to see how these pieces fit together. So generally the first half of the goal is pointing towards one of the major dynamics in the case conceptualization in order to address something that was identified in the clinical assessment. So it's like this huge puzzle pieces start coming together as you're working on these. And then again, you're putting the measures so you're able to maintain this for how X number of weeks or months to measure that progress has been made. And then you can see once those big pieces are in place that the interventions just kind of roll off the tongue. They make a lot of sense because you know exactly where you're going and what you're doing. Then again, in terms of completing the treatment plan, in the closing phase, your therapeutic tasks are basically develop the aftercare plan and then develop some closing client goals, some late phase goals. And this may be determined by the theory of health. Solution focus doesn't really necessarily have predetermined ones. And then you want to finally look at the client perspective in the treatment plan. So in the closing phase, you're just doing the last, kind of wrapping up any loose ends, sometimes working on more wellness-oriented goals rather than just addressing problems, and kind of getting the clients ready to go forward without you in their lives to be successful in solving the problems that they have had and that they came to you with, as well as being able to solve future problems as they come. Because we can be guaranteed that there will be more problems down the road. That's just the way life is. So in this final phase here in the solution focused plan, we've been looking at they're going to be using scaling questions to identify the warnings that they're backsliding. It's a great technique to use actually with solution focused or any approach, is to be saying what are some of those warning signs, and here they're using scaling to do that. And then in terms of the final goal, like I said, solution focused doesn't come with prepackaged final goals, but this last one is to increase the couple sense of solidarity as parents and as a couple, to reduce a lot of the hopelessness, the conflict, and the irritability that they came in with. And so as you can see, if you can envision all this, we've got them parenting better together, reducing the triangulation, we got intimacy back, and we got them kind of clarifying their roles. And so at the end, they're developing this strong sense of solidarity and clarity in terms of who they are both as parents and as a couple. And that is going to be the kind of the final goal that kind of hopefully solidifies things so that they will be more stable and better able as a couple and a family to deal with the problems that are going to lie ahead of them down the road. So again, here you can look at in terms of the client perspective that the husband is more optimistic than the wife about this plan, and so the therapist writes a little bit about how all those pieces fit together. So that's basically the treatment plan. This is a very long, hairy, gory treatment plan, and I promise if you can do this, you can do about any other treatment plan out there on the planet, because I don't think it gets more complicated or thorough as this one. But this should really give you a solid perspective. And even if you end up in an agency where you don't have to write such long, hairy, gory things, you're doing basic symptom plans like reducing tantrums, reducing depression, reducing basic psychiatric symptoms. Even if you're doing that, it's very important, at least in your mind, to go through that case conceptualization and pick out the key core dynamics that you plan to change, because that's really going to be the treatment. And I think a lot of especially newer therapists get very lost because they're just focused on, I'm going to try to reduce depressed mood this week. And they don't understand enough or have a clear enough vision as to how to do that. And that comes through your case conceptualization and having goals that reflect that underlying dynamic that needs to change. It really keeps your focus very, very clear on what you need to be doing each week in therapy to best help these clients meet their goals. So I wish you the best in your treatment planning, and enjoy.